So, good morning and a very warm welcome to all of you to this virtual session of the Gobeshona 5 conference organized by ICCCAD Bangladesh. Gobeshona has always been a platform for sharing knowledge, building partnerships, and inspiring innovative solutions. So, we would like to wait a few minutes before we start our main presentation, so that other participants can join as well. So we'll be starting within 1 or 2 minutes. Thank you, everyone. So without further delay, it is my pleasure to welcome you once again. So we will be proceeding with our presentation. And I would like to request our attendees to mute yourself, and please join the discussion during the discussion session. And you can always ask your questions in the chat box as well. So I am Azwad Bari. I'm working as the Knowledge Management and Learning Officer at Pathfinder International. So I'll be the moderator and as well the first presenter. So just give me a minute. I will share my slides with you. Is my screen visible? I think my screen is visible. So I may proceed as well. Thank you. So basically, in our presentation, we'll get to know about the Women-Led Climate Resilience project, along with some of our implementation insights, study findings, and some relevant case stories. At the beginning, we'll be demonstrating how women in the remote areas of our project have empowered themselves by adopting different strategies in their health, nutrition, livelihood, and readiness. Afterwards, we'll be showcasing a comprehensive health facility assessment implemented by our project, which identified critical gaps in services, infrastructure, and preparedness, leading to targeted improvements in SRHR. And finally, there will be some case stories supplementing the impactful interventions of the Women-led Climate Resilience Project. So now let me actually introduce the Women-led Climate Resilience program, which is familiar by the name of Dishari as well. So basically the goal of this initiative is to ensure that women and girls in low resource settings have consistent access to quality health services, along with the health system to withstand future shocks and crises. Our work is mainly driven by three key objectives. Though, if you look at the first one, at the community level, we aim to empower women and girls by uh, equipping them with knowledge, tools, networks, and resources so that they can address today's health challenges and tomorrow's emergencies. Secondly, within the health system, we focus on building resilient, adaptable, and high quality services that can meet essential health needs uh, in the communities during the time of emergency. And third, through collaboration and learning, we are developing an integrated framework that fosters ongoing adaptation, supports implementation, and generates evidence to inform decision-making advocacy. So here, let me begin by setting the context for why this Dishari, Women-led Climate Resilience program is so critical, especially in the climate vulnerable regions of Bangladesh. So at the very beginning, women in these areas actually encounter limited access to healthcare, particularly during a climate-related disaster or climate-induced event. On top of that, financial hardships and the loss of livelihoods from climate shocks leave many women without the means to seek care. And these vulnerabilities are further intensified by increased risk of gender-based violence, especially in the aftermath of disaster. Even safety nets are weakened during that period of time. So disasters, it's not only destroys infrastructure, they also lead to social isolation, especially for women who are left behind while uh, their partners migrate for work or recovery efforts. So if we look at our primary beneficiaries, we work with community health workers, communities, pregnant women, health facilities, adolescent girls, boys, couple, and the administrative, rural level administrative government bodies and national level stakeholders as well. So if we closely look into this figure, then we'll be able to see that we are trying to actually preparing a resilient community by supporting the prime components as disaster management committee figure that addresses disaster management, women, pregnant women, volunteers, youth, and school, all the elements here actually. We are actually designing and implementing various interventions which is helping these audiences capacitating to be resilient and better for any emergency shocks. Like uh, by capacitating all these actors and audiences, we'll finally be able to make a community, including their other beneficiaries, resilient. So if we look at the target of our project, we are targeting to reach nearly 5 million women, adolescents, and I think these are just numbers, but the impact are pretty much big. If we are able to reach these our targets, the impact will be huge. And I'll not be repeating the numbers, as you can see in the slides. So just moving on. So I want to finally end my presentation with our project video, and I hope the audience will enjoy every bit of it. So thank you. Let me turn on the video.
ভৌগোলিক অবস্থান ও জলবায়ু পরিবর্তনের নেতিবাচক প্রভাবে বাংলাদেশে ক্রমাগত প্রাকৃতিক দুর্যোগের পরিমাণ বেড়েই চলেছে, যা প্রান্তিক জনগোষ্ঠীর নারী ও কিশোরীদের নিরাপত্তা ও স্বাস্থ্যসেবাকে বিঘ্নিত করে। মানসম্মত ও নিরবিচ্ছিন্ন স্বাস্থ্যসেবা নিশ্চিতকরণে সিলেট, সুনামগঞ্জ, কিশোরগঞ্জ, নেত্রকোনা ও কক্সবাজার জেলায় পাথফাইন্ডার ইন্টারন্যাশনাল Advancing the Leadership of Women and Girls Towards Better Health and Climate Change Resilience বা দিশারি প্রকল্পটি বাস্তবায়ন করছে।
দিশারি আমাদের কিশোরগঞ্জ জেলার হাওর বেষ্টিত উপজেলাগুলিতে কাজ করে যাচ্ছে। প্রান্তিক জনগোষ্ঠী এবং আমাদের সেবা গ্রহীতা তাদেরকে ট্রেনিং এবং উঠান বৈঠকের মাধ্যমে সচেতনতা বৃদ্ধির লক্ষ্যে কাজ করে যাচ্ছে। উঠান বৈঠকগুলোতে আমাদের হাওর অঞ্চলের গর্ভবতী মাদেরকে নিয়ে এসে তাদেরকে এএনসি সেবা, পিএনসি সেবার গুরুত্ব বোঝানো, সেফ ডেলিভারির গুরুত্ব বোঝানো, একটা ব্লাড গ্রুপিং ঠিক করে রাখা, ডেলিভারিটা কোথায় হবে, কার মাধ্যমে হবে এবং সেই ট্রান্সপোর্টেশন কস্ট যেন ডিলে না হয় সে ব্যাপারে আমরা তাদেরকে সচেতন করে থাকি।
প্রকল্প এলাকায় দুর্যোগ মৌসুমে গর্ভবতী নারীদের চিহ্নিত করে সেশন পরিচালনা করা হচ্ছে, যেন হঠাৎ দুর্যোগ এলে গর্ভবতী নারীরা তাদের করণীয় বিষয়গুলো সম্পর্কে অবগত থাকেন। এই সেশনগুলোতে স্বাস্থ্যকর্মী ছাড়াও স্থানীয় নেতৃবৃন্দ তথ্য দিয়ে সহায়তা করেন।
যেসব মায়েদের সম্ভাব্য ডেলিভারি ডেট হচ্ছে বন্যাকালীন সময়টুকুতে, তাদেরকে নিয়ে আমরা কিছু সচেতনতামূলক সেশন করি, যাতে করে তারা ওই দুর্যোগের সময় তাদের কষ্ট বা সাফারিংসগুলো কমায় আনতে পারে এবং তাদের প্রস্তুতি থাকে।
দিশারি উঠোন বৈঠকে যেতাম যখন আমার মেয়ে গর্ভে ছিল, ওখানে গিয়ে অনেক কিছু শিখছিলাম। ডেলিভারি হইলে কি দিয়ে নেওয়া লাগবে, নাও নাকি গাড়ি ঘোড়া দিয়ে। তারপর আমাদের চেয়ারম্যান এখান থেকে বলছে ডেলিভারির সময় দরকার লাগে আমি নাও দেব। তারপর আমার যখন ব্যথা হচ্ছিল, আমাদের চেয়ারম্যান সাহেব এই নাওটা দিয়ে আমাদেরকে নিয়ে বাগুলপুর চলে যায়। যাওয়ার পরে এখানে আমার মেয়ের ডেলিভারি হয়। হওয়ার পরে আমি আর আমার মেয়ে আলহামদুলিল্লাহ সুস্থ আছি।
দুর্যোগের সঠিক পূর্ব প্রস্তুতির লক্ষ্যে দিশারি প্রকল্প ইউনিয়ন পর্যায়ে দুর্যোগ ব্যবস্থাপনা কমিটি এবং রেজিলিয়েন্স ভলেন্টিয়ারদেরকে নিয়ে এলাকা ভিত্তিক দুর্যোগ চিহ্নিতকরণ এবং তার প্রস্তুতির পূর্ব পরিকল্পনা করে। সেই সাথে বিদ্যালয় পর্যায়ে শিক্ষার্থী ও শিক্ষকদের ট্রেনিং প্রদান করা হয়েছে, যেন দুর্যোগ এলে আশ্রয়কেন্দ্র হিসেবে ব্যবহৃত স্কুলগুলোতে সঠিক প্রস্তুতি ও ব্যবস্থাপনা বজায় থাকে।
দিশারি প্রকল্পের মাধ্যমে আমাদের স্কুল ডিজাস্টার ম্যানেজমেন্ট একটি কমিটি করা হয়েছে। সেই কমিটির মাধ্যমে আমাদের একটি স্কুল সেফটি প্ল্যান করা হয়েছে। এখন এই স্কুল সেফটি প্ল্যানের মাধ্যমে আমাদের বিভিন্ন সমস্যা চিহ্নিত করা হয়েছে এবং সেই সমস্যাগুলো সমাধানের জন্য একটি কর্মপরিকল্পনা গ্রহণ করা হয়েছে।
দিশারি প্রকল্প থেকে আমাদের স্কুলে একটি 2 দিনের ট্রেনিং করা হয়েছিল। আমরা স্টুডেন্ট কাউন্সিলের সবাই সেখানে অংশগ্রহণ করেছিলাম। সেখানে আমাদেরকে জলবায়ু পরিবর্তনের ঝুঁকি সমূহ এবং বাংলাদেশের বিভিন্ন প্রাকৃতিক দুর্যোগ আমরা কিভাবে ক্ষয়ক্ষতি কমে আনবো সেই বিষয়ে আমাদেরকে বোঝানো হয়েছে। দুর্যোগে আসলে গর্ভবতী মায়েরা, শিশুরা এবং বৃদ্ধরা বেশি ক্ষতিগ্রস্ত হয়। তাদেরকে আমরা কিভাবে রেস্কিউ করব, এই ক্ষতিগুলোকে কিভাবে আমরা ওভারকাম করব, সেই বিষয়ে আমরা একটা সেফটি প্ল্যান তৈরি করেছি। সেগুলো আমরা আমাদের ক্লাসের শিক্ষার্থীদের সাথে আলোচনা করেছি, বন্ধু বান্ধবদের সাথে আলোচনা করেছি, পরিবারের সদস্যদের সাথে আলোচনা করেছি, এমনকি আমরা আমাদের প্রতিবেশীদের সাথে আলোচনা করে তাদেরকে এই বিষয়ে সচেতন করার চেষ্টা করেছি।
এছাড়াও দিশারি প্রকল্পটি নারী ও কিশোরীদের সক্ষমতা বৃদ্ধির লক্ষ্যে এবং দুর্যোগের ঝুঁকি মোকাবেলায় তৃণমূল পর্যায়ে দক্ষতা ও নেতৃত্ব বিকাশে কাজ করছে। নারী ও কিশোরীদের স্বাবলম্বী করে তুলতে বিভিন্ন জীবিকায়ন বিষয়ক ট্রেনিং প্রদান করছে, যার মাধ্যমে তারা বসত বাড়িতে সবজি চাষ, ভার্মি কম্পোস্ট তৈরি, কম খরচে হাজল পদ্ধতি ব্যবহার করে মুরগির বাচ্চা উৎপাদন ইত্যাদি জীবিকায় অংশগ্রহণ করছে।
দিশাইদাল থেকে আমার আরো একটা ট্রেনিং দেওয়া হয়েছে যে বার্মি সার তৈরি করা। এখন আমার বাড়িতে আমি তৈরি করতেছি। এই সার গিয়ে আমি আমার সবজিতে ব্যবহার করতেছি। এরপর আমার পাড়া প্রতিবেশীরা আমার কাছ থেকে কিনে নিতেছেন। কৃষি কর্মকর্তা ভাইয়া আমারে যোগাযোগ করাই দিয়েছেন, তাই এই কৃষি অফিস থেকে কিনে নিবেন। তো এটা থেকেও আমার একটা জীবন মান উন্নয়ন হইতেছে।
দুর্যোগের পূর্বে ও দুর্যোগ পরবর্তী সময়ে আশ্রয়কেন্দ্র, স্কুল এবং সেবা কেন্দ্রগুলোকে প্রয়োজনীয় সেবা প্রদানের জন্য উপযোগী করে তোলা দিশারি প্রকল্পের একটি অন্যতম লক্ষ্য। পরিবার পরিকল্পনা সেবার সহজলভ্যতা এবং এর ব্যবহার বৃদ্ধির লক্ষ্যে স্বাস্থ্যকেন্দ্র, স্যাটেলাইট ক্লিনিক এবং কমিউনিটি পর্যায়ে স্বাস্থ্যসেবা কর্মী সহ স্বাস্থ্য ব্যবস্থাকে আরও শক্তিশালী করার লক্ষ্যেও দিশারি কাজ করছে।
Well, thank you so much for patiently listening to my presentation. I would also like to thank three of our implementing partners, FIVDB, Poppy, and IPSHA, who are implementing our projects in 5 different project districts of Bangladesh. So now I would like to request our next presenter, Manbira Sultana Apa, to kindly introduce yourself and proceed with your presentation. And also, I'll be requesting the attendees, if you have any questions, please use the chat box, and definitely we'll be taking your question in the discussion session. Thank you. Over to you, Manbira Apa.
Thank you, Ajad Bhai. Good morning, everyone. I'm Mirza Manbir Sultana. I work as male advisor at Pathfinder International. I will be presenting some of our experiences that from the the WLCA project that we have so far experienced. Let me share. Is my screen visible?
Yes, Apa, your screen is visible. Could you please?
So building on what the project background, we have my presentation. I will be presenting the findings from our work at the community level. So our first objective was to building a resilient community through women and girls. So our intervention for women, we actually implemented at the community level, and but we wanted to assess how those interventions work. So we did a small assessment within our internal team. It was a mixed method approach, and we actually collected qualitative data, and where we had like 24 in-depth interviews of the women who participated in groups, and 4 FGDs from different women groups in 3 districts. And we also collected routine monitoring data from our partners. So the modality of the intervention at community was that we actually established around 654 groups in 5 districts in Bangladesh. And these groups were established until the December of 2024. One of our partners will establish few more groups in Sunamganj and Sylhet, but rest of the partners will have already established their groups. So around 54 groups, we have like 16,616 women in these groups. And so the modality of our intervention was that we provided courtyard sessions, and the sessions, to provide those sessions, we build customized flip charts based on different climatic areas in our climate vulnerable districts, 5 districts that we are operating currently. So the sessions included the climate and disaster, health and nutrition, and sexual and reproductive health rights, adolescent health, WASH, and gender climate resilient livelihood. In addition to informing women through these groups, we actually linked a selected group of women with the Department of Agricultural Extension, and they provided in different areas, different modalities were taken. They provided, agriculture, climate resilient agriculture, poultry, and other, livelihood training to these women based on their own training module. Also, few women from Kishoreganj were linked with Department of Youth Development, and they received training on cattle raising. In addition to this, we actually include throughout the project process, we had linked these women with different service facilities in those localities, particularly community clinic, so that they can access health services, Upajala Health Complex, Department of Agricultural Extension, Department of Youth Development, and other different facilities wherever it is required. So because different partners had a customized way of applying the methods, so they had implemented additional processes in different areas based on the requirement of the climate vulnerability and other area requirements. So through this assessment, we tried to find out what are the accomplishments that we actually achieved through these interventions. If we look at the sessions that we have taken, we've seen that women actually, through the sessions, they actually learned about different their climate vulnerabilities and how they can cope with that. It's not that they didn't have any information about coping or they didn't cope. They had their own mechanisms. What we did through the sessions was that we reinforced whatever available knowledge was there, and we actually provided them with some new knowledge, new information, and these linkages had a compounding effect on the knowledge and information they already had. So when we asked how it was impacted them, they claimed that they are now better prepared. They now know, it is reinforced their knowledge that they now need to be prepared whenever they learn about a disaster, that they should have dry food, they should have candles, matches. They previously also knew it, but they actually didn't had to thought about it that much. But because through the sessions it was reinforced so much that now in the recent 2024 flood, they were more prepared. They had those things, and when they were waterlogging was there in Sylhet, they had all these things and they were prepared, and they actually had better prepared from 2022 flood that they faced. And because they learned climate resilient livelihood, they had some vegetables in their sack gardening inside of their house, and they could use that. They didn't have to starve, or they didn't have to only depend on dry food when they were inside of the house. They also have knowledge and preparedness for other vulnerable groups, the most vulnerable groups, particularly women, pregnant women, elderly. So now they say that we now know who has a boat, and we talk to them, and we prepare that whenever there is a pregnant woman there and there is a disaster, we will take that boat, we'll take support of that, and we will take the most vulnerable to the shelters. So, and also we will take elderly. We now know the services available, like community clinics. We will first go to the community clinic, and then we'll refer them whenever they need a service. We will refer them to the community clinic. If they need further services, they will be referred to other places. They also learned about the early warning system as well, where they can call a specific number, and particularly in Kishoreganj, the Howrah area, they have water in water logging and water increase happens very quickly. So through that number, they can select their areas and they can learn when there will be water in the Howrah, when there will be sudden flash flood, and they can prepare their cultivation and for that, and also when their husbands should come home because there is a impending disaster. Then we also women claimed that through the health, nutrition, and wash sessions, what they learned and how they are prepared. So through the information, they are now more prepared with the information that they now have to do NCs. They now learned about family planning practices and where they can get family planning services. Particularly, they've started going to the community clinics for family planning and other services, and also their wash behavior has changed. They now know that they have the key times when they need to wash their hands, and then their toilets needs to be clean. Also, with this information and service available knowledge about the availability of services, their practices also changed because of the information and because of the different interventions that they have received. Their mobility has changed. Now these women support each other when they need some services. When someone is sick, they don't actually have to depend on their family, and family also allows them to go to the community clinic and to some extent to the Upazila health complex when additional services are needed. So we can see that there is a certain change, and it's not only the information, it's also the other different intervention which had a compounding effect on women. And also they learned about the menstrual hygiene behaviors. Even some of the adolescents who were part of the groups, they also learned about the behaviors, and now they are practicing the healthy behaviors the way they claimed it. And there were also a gender session, but the empowerment and the voice and leadership that has been established is not through only the gender session. Of course, gender session had a role. The gender session give women a certain confidence that they should negotiate, they should raise their voice, how and when, and there should be a equity in their relationship with their spouses and how they should establish it. So they claim that we are now practicing those and we can actually raise our voices. But always they link their voice and leadership with the other things that they have received and the other activities they were involved in, particularly climate resilience, livelihood. Because of their income and because of their livelihood involvement, the contribution has always they linked it with their confidence and all those things that they achieved. That this has been possible because they have a certain income currently. Now because of this, they also say that now we dream that at least we should not early marriage should not be there for our children, and we have high hopes for our daughters so that they can have education. And also, that's what we are saying, that through these group activities, and then they receive training, they started different processes, they now have mobility. Now they can go outside and go to different places, up to the Union Parishad, up to the Upazila level, talk to different people, and they now have confidence to speak to other people. And of course, they have their mobility has changed, and they can access it with the help of other women in the group. They don't have to take support from their spouses all the time, like previously they used to do. They used to take support from their spouses for and they always need to ask for their permission where they have certain kind of decision making capacity that they are stating. We also seen that women claim that they have developed certain level of leadership capacity. Even though this is the first time they came to this group, they become group leaders. Previously, they had a thought that they were just a daughter-in-law and they had no other choices. They need to listen to everyone, but by discussing in the group, by continuously participating in the group activities, it gives them certain level of boost in their leadership capacity. And they claim that we actually went to different local government and asked for old age allowance, widow allowance, and we actually stopped early marriage. And they actually are involved in other different livelihood activities, and they contributed in their family. Finally, the women were all linked with livelihood activities, and they were linked with the Department of Agriculture and Department of Youth Development for training. So it happened in different places, in three partner organized it differently, and most of the women actually were selected to participate in the Department of Agriculture's training. And the selected women who received the training, they received certain other incentives as well, like seeds, water jars, and nets, all these things for implementing the cultivation of climate resilient vegetables, sometimes crops and other things. And few women also were trained in the Department of Youth Development on cattle raising. So around 16,616 women who are participating in the groups, they received the livelihood information from the sessions. And 854 received the training. They were the selected women. 611 received training from the youth development. And among these 16,616 women, 2,490 women actually initiated livelihood activities. Most of them initiated vegetable cultivation and also poultry rearing. Some women also involved in other different activities, and they were linked through different other projects as well. And but they said that this is the first time they actually went out through the activities of WLCR project, and now they are confident and they are exploring other different livelihood activities. So finally, what we actually received from these activities that women were involved in, particularly they became climate resilient, and now they know how to be prepared for their for next disaster or impending disaster that they will be happening. And also when they received the training and the incentives, and when they came back and they implemented the climate resilient livelihood activities, other women in their areas, they were interested in that and they learned from that. So there is a cascading effect in the wider society, and not only the group women, other women also are participating in vegetable cultivation, and they're also some of them are so encouraged that they are also participating in the group activities. They are also listening to the group sessions, and they are practicing those in their households. And we have observed that women from different other not part of the group, their other relatives, they are also initiated vegetable gardening and poultry rearing, particularly the different methods. They said that we previously tried to rear chickens, but because of the current vulnerable areas, they couldn't, raise them properly, and sometimes they used to die. But now they know the Hajam process, and they don't die anymore, and their vegetables also grow properly because they know how to do the compost fertilizer. And so everyone is now, whoever started the vegetable, now they can grow it and they can provide for their family during the disaster, and even when there is no disaster. In addition to this, they actually sell the vegetables, which gives them a certain level of income, which is might not be very big, but because they didn't have, many of them said, at least 30% said that this is the first time we had some income in our hand, and we now have the decision-making abilities for our own income. We think that this income is ours, and the spending decision is on ours as well, but we spend it for ourselves and particularly they spend it for their family and their daughters, their children's small needs. And also they contributed to household needs as well. Whenever husband or spouses, they need it, they contributed to the household. And they always link it with their status in their household. Because of their involvement in the groups, they say that their status in the house and their income level, contribution in the income contribution in the household, their status in the household has changed, and now their spouses listen to them, and they value their opinion, and they discuss things with them, particularly family planning and children's education. They now can share, even they have a health problem, if they want to go. Those barriers of mobility has been lifted for them, changed to some extent for them. They don't always need to ask permission or always need to ask accompanied by husband or other male members to go to some places. They can be accompanied by other group women, and husbands now trust them because they already gained those accesses, and they also apply to Department of Agriculture for more training of other women. So there are visible changes in their behavior and the level of activities they are doing currently, which they previously never used to do. And because they are taking decisions and because they have explored different places, now husband also get information from them, and then they learn from them. So they understand that this has a effect in their family status and family's income. And we have also seen that families say that their income level has changed from before during this involvement in the groups. And we can see that women's decision making and overall agency and empowerment has changed through these interventions. So we believe that through the interventions, there is a visible change, but we also learned that, if the sessions and if the information are continuously and repeatedly provided to women, then they can recall it and they can utilize it more effectively. And also the engagement of male, which happen in certain places, also boost their capacities. So these are all this information and the linking and the incentives. I think it had a compounding effect in the building establishment of climate resilient community through the help or establishing women as change agents. Thank you. So now I will be requesting Arif Bhai.
Thank you so much, Manvira Appa, for your wonderful presentations. So indeed, if we can pull off the leadership preparedness and other awarenesses among women and the other beneficiaries of our project and the other vulnerable populations as well, we can definitely mitigate the disaster effects. So thank you again. And I would like to request my colleague Arif Azad Khan Bhai to kindly introduce yourself and share your presentation. Over to you, Arif Bhai.
Hello everyone, good morning. I'm Arif Ajad Khan, working as Monitoring, Evaluation and Learning Officer at Pathfinder International. As all you know, our project, Women-led Climate Resilience Project, There are three objectives associated in this project. One is community related. Second one is health facility preparation related for disaster time, and another is collaboration and learning. As a part of objective 2, preparing the health facility for the disaster time at the initial time of the project period. We have assessed health facilities of our project areas. Especially, we have choose the project area which are most vulnerable in terms of flood. Kishoreganj, Netrokona, Sylhet, Sunamganj, and also cyclone prone area, Cox Bazar district. Among the 5 districts, we have selected 20 more vulnerable districts in terms of climate vulnerabilities. And among them, we have conducted health facility assessment of these vulnerable areas. In our government systems and many development partners are generally continuous assess the health facilities in terms of different objectives. But through our project, we have take chance to see what's the situation of our health facilities of the flood-prone areas in terms of disaster preparation. We have conducted a baseline assessment in those 4 districts actually. Sunamganj, Sylhet, Kishoreganj, and Netrokona. In our assessment, we have taken consideration both primary healthcare facilities and referral health facilities as well. Though the most of the facilities are primary level health facilities, there are in our assessment we have considered to assess community clinic, union health and family welfare center, rural dispensary, and referral health facility. We have assessed mother and child welfare center and the Upajala health complex. We have developed basically we have for the assessment we have adopted a WHO guidelines. Basically, there is a checklist that follows this basically measures the health facility preparation of regarding the disaster preparedness. We have follows these tools and customized as our requirement. And then we have opportunity to take the IRB approval from the IRB board, but we have identified this is a non-human subject research studies. Therefore, we did not require the IRB approval. After then, we have oriented our enumerator, and we have tested the health facility tools in our selected health facilities. We have collected the health facilities data through open source Kobo Toolbox tool. And we have, after the data collection, we have showed our result to our respective district health facility authorities. Both DGFP and DGHS basically own those facilities. We have presented the health facilities to them. And we have conducted 4 workshops and shared our findings in the respective districts. And then we have conducted a national level workshop where our different level of facilities authorities and the different level of stakeholders were there. We have presented our results as well. At the time of time of assessment, our project area affected unprecedented flood, and there we have found that among the health facilities, there were 52% health facilities were closed in that time. And we have found that the health facility was closed, alarming 1 day to 150 in 50 days. And 18 community clinic and FWC, we have found that closed more than 10 days in that time. When we assess the infrastructural strength of our health facilities, there we have found that 22% health facilities we found that are toilet are non-functional. Among them, the primary healthcare facilities status is much weaker than the referral hospital. Here we have found the 26 community clinics and 14% FWCs toilets are non-functional. And in terms of female toilet, we have found that only 79% health facility have only 21% health facility have found that their female toilets are available. In terms of power supply availability, there we have found that 22% health facilities don't have the final functional power sources in the time of assessment. And we have found that the electricity is the dominant in terms of power supply. 74% have such facilities. And in the primary sources, we have found that 3% health facilities have the solar system. But in terms of secondary power sources, there is the unavailability or limitation of there. But in terms of 24 hours power supply availability, there also the scenario is not that much good. We have found only 54% health facility informed that they have the 24% power supply availability. In terms of clean water supply availability, we have found that the community clinic and FWC have less clean water supply availability, but in the RD or USC or or MCWC, there have much better situation in terms of clean water supply availability. We have also measured the health facility cleanliness status. It's basically assessed by the observation of our enumerator. There we have found the facilities inside cleanliness is 26%, but outside we have found that 13% health facilities are fully clean. Again, the CC or primary healthcare situation is not that much satisfactory than the referral hospitals. We have also tried to find out what's the information status available for the client in the health facilities premises. There we have found and that USC and MCWC have a better position in terms of available such information in the health facility premises. We have found that 70% health facilities having the citizen charter. Among them, the 25% of the health facilities of CCs are not available. And FWC, it's a little bit good position, but 21% health facilities that found that they have the citizen charter displayed in the time of assessment. Again, we have also asked if there is reproductive health services are available displays in the health facilities, which is understandable for the client. There we have found that again, CC and FWC have not displayed some such sorts of information. For example, CC has only 48% CCs have found such reproductive health services information displays in the health facilities, which is convenient for the client to understand and visible. And in terms of FWC, there have 73% health facility have such information. through the assessment, we also gathers the service availability of the health facilities. There we have gathers information of FP method availability. We have found that the community clinic, 12% at health facility didn't found at the assessment, they are not available for oral pill to provide the clients. And the 44% health facilities, community clinic informed that there are not health services for such injectable services. And in terms of IUD, which also not available in FWC level, which should be available, but 27% health facility FWC informed that there is not available. In terms of permanent method NSB and vasectomy, we were found there should be available in MCWC, but we did not found the time that this service available and the time of assessment. In terms of cesarean section, we found that among the 14 referral health facilities, USA and MCL, there we have found the 15%, at least 7 health facilities where cesarean sections were functional and trained at that time. And FWC who should have the basal and delivery services, but we have found that there are some lack of basal and service delivery available in that time of health facilities assessment. And in terms of GBB related service availability of the health facilities, there we have found that CC primary healthcare situation is not not good compared to the USA and MCWC. We have found that USA have the better position to provide the GBB related services. For example, the clinical management of rape, such facilities are available in the USC level. But which is not available, we have found that others referral health facilities, for example, MCWC. But we have, in terms of CC and FWC, we have some little bit service regarding the GBV or related services in the health facility level. And in terms of aversion care facilities, which is government system, there is no such facilities of the community level, but community clinic level. But when we see the FWC and USC level facilities, they are also found or some sort of lacking service availability of such services. For example, we did train in terms of manual vacuum aspiration train service provider availability. We also found there lacked in MCWC level. And in terms of referral hospital, there is little bit better than the primary health care. In terms of comprehensive abortion care train service provider and service availability, again, there the situation is similar, what we have seen the mineral aspiration trained services. And long-acting reversible contraception services, which also seems not the satisfactory level in the FWC level and the MCWC USC level at the time of we have assessed in the health facility time. And in terms of 24/7 health services, we found that which also lacked in MCWC referral hospital as well. That was informed by the responder. And in terms of WC, we have seen that some sort of service should have, or there should have availability of 24/7 services, but there also we have found that the lack of such services 24/7 at the time of assessment. When we see the preparedness of the health facilities, there were 19 questions were asked based on the World Health Organization checklist. There we have found what the status of the preparation. Here we have mentioned the 5 indicator of the health facility preparedness status. Here we have found that most of the health facilities have informed that they are not prepared regarding those indicators, and in some cases we have found that they have the preparation of against the indicator, but in some cases we have found that those preparation also involved in the of the community people of the health facilities. Therefore, we have found in some cases they have the better preparation and good and better indicator stress we have found. But most of the indicator we have found, all of the indicator we have found that the preparation of 2 months supply of all SRS essential commodities of health services, we have found its status is better than the others indicator. We have found that in terms of this, we have the better preparation. But when we see the other indicators, there is not the good conditions. When we further dig down, what's the status of the health facility preparedness? We have basically 3 criteria. We have each question of if a health facility is better prepared, high prepared, then we have provided score 3. For medium prepared, we have provided 2, and for the low prepared health facility, we have provided 1. And then we have converted the all facility status into 100, and then we have found that our community clinic, primary care community clinic is not in good condition. When we see the average score, we found the community clinic score very low, which is 37. And when we see the referral hospital or district level big hospital, we found that this score is 62. So again, we have found that the primary healthcare health facilities preparation is much less than the facilities of referral hospital, MCWC, and USC. Basically, these are the indicators of how tools we have adopted. There are different type of indicator. For example, there are the some service availability, SRS or service availability, some sort of planning, or some sort of infrastructural situation of the health facilities and their planning. Such indicator was considered in our assessment. And what's the planning of the health facilities? Here we have found that only 2% health facilities we have found that have post-crisis recovery plan, existing plan to comfort a health disaster. And in terms of regular community planning with the health facilities, have the community planning, we have found only 19% health facilities have the such planning. And after the evaluation of the structural and non-structural condition of latest disaster, we have found it's also the only 25% health facility informed that they have evaluated such conditions, or government authority have actively evaluated the situations of the structural condition. And in terms of shading devices of the health facilities, we have found that 32% health facilities have some sort of shading devices or protective equipment to protect them from a um, heavy wind or other climatic disaster. So there we have found that they have some facilities have informed that they have the disaster preparedness budget, annual budget, which they basically collect or gather with the health facilities management committee or other community involvement. They some sort of collect such disaster preparedness budget. So they inform that they have the annual budget of disaster preparedness. Following our results in our project, we have taken many initiatives to address those gaps in our project. Among them, there was advocacy. We did advocacy in different level, health facilities level with the community. We have also advocate with the local authority. For example, Union Parishad, we have conducted different um, workshop with them, and we also did some workshop with Upazila level, district level, and also in the national level, disseminated of our health facility assessment results. And we also considered to develop a health facility preparedness checklist in the supervisory visit of the government system, which was tested, but which not still rolled out. But we have tested a supervisory checklist other than the government checklist to check what's the status of the health facilities regarding the disaster preparedness. Besides this, we also considered to capacitate the health service provider of the project areas regarding the disaster preparedness. We have considered the minimum initial service package training, which ensures the SREs in the disaster time, and also we have considered the gender training, which basically gender is not that much looked at the time of disasters. We also capacitated such type of training, and also we considered the snakebite management training for the clinical service provider and the non-clinical service provider, as the hower prone area is a flood prone area is second cause of snakebite. We also capacitated them with the snakebite management training as well. And we also conducted the regular FWC management committee, help the government to conduct the health facility management committee, and we have taken opportunity to create the contingency plan of the health facilities and planning for the better preparation for the upcoming disasters of a health facility. And besides the capacity development of the health service provider, developing the planning for the health facilities, capacity development of the health service provider advocacy, we also found that the health facilities of those areas severely affected by the flood, and due to flood, many health facilities become unusable due to a flood. We have renovated a few facilities in our project scope so that they become functional and whole, and we are activated those health facilities, renovating them, and they are in a good condition and they are functional now. And as this is the end of our project year, we have a plan to revisit the health facilities of our project areas, and to check what's the status of the health facilities now after the project intervention of 4 years. And this is some pictures of our health facilities. Here we have found that the community clinic and FWC. here providing service of the client by the service provider. Here we have found that a good condition of FWC delivery room. So yes, thank you everyone.
Thank you very much. Thank you very much, Arif Bhai. It's an excellent presentation. So, echoing with you, we can expect that since the project has shared the findings with the government, so we can definitely expect that along with the development agencies, the government will take necessary steps to actually fill in these gaps. So thank you again. So before moving into the next presentation, I would like the attendees to do one thing. The next presentation is pretty interesting. It's regarding a compilation of stories. So some of us, I think all of the participants have experiences regarding some stories, thematic stories. So I would like to tell the participants to volunteer that which of the stories you have liked the most, and you can share similar type of stories when we move into the discussion session. And you can definitely ask questions in the chat box as well. So now I would like to request my colleague Shahnaz Parvin Jonaki Apa to kindly introduce yourself and move on with your presentation. Thank you so much.
Am I audible?
Yes, you're audible. Go ahead.
Thank you. I would like to introduce myself first. Hi, I am Shahnaz Parvin Jonaki. I am working as Communications and Documentation Officer at Pathfinder International. And today, as Azad Bhai already mentioned, I will try to present some stories from the fields. As a communications officer, one of my favorite thing is to visit fields and collect the stories, because it's wonderful to see the real impact behind the data. I will just give me a minute so that I can share my screen. Can you see my screen?
Yes, it's visible.
So I will share some stories from Women-Led Climate Resilience Project, and we will see whatever that Manbira Apu and Azwad Bhai and Arif Bhai was sharing, how it has been impacting the real human in the project areas that we've been working on. Sorry. There are so many stories, but I have chosen some stories that actually shows how women and girls are leading climate resilience in their locality, and how they're contributing in making their community more resilient. So I'll be telling some inspiring stories of women and girls in our 5 project areas. The first story is about Kulsum Akhtar. So Kulsum Akhtar lives in a flood-prone area. So flood is a common phenomena in her daily life. So she didn't used to farming a lot, but after joining the courtyard sessions in our program, she tried to grow ginger. And she thought, like, what would she do if the water rises during the flood season, and how she's going to cope with the floods, and how she's going to make sure that her crops are safe. So she has come up with an wonderful innovation, and she started growing the ginger in sacks filled with soil. And this method actually keeps the ginger crops higher above the ground, which saves them from the flood water. And it's also gives one kind of mobility to these crops, because you can always move the sacks when the water level rises. So this has been a great example of how a climate smart farming should be. And she's looking forward to selling those gingers in near marketplaces. And this farming actually kind of, as I have already said, that she didn't used to farming, so this farming has kind of empowered her in her life, because now her husband listens to her, and she kind of makes a decision, important decision about the household activities. And she also has some problem in her eyes, and despite that problem, she's looking for hopes in her life through this farming. So her story inspired me a lot, that this women is kind of like the heart of the resilience. And Kulsum Akhtar is not only one. There are so many women's in the 5 project areas was adapting climate adaptive agriculture and poultry and other things that they are going to do for their financial independency, their leadership, and as well as being in a place where they can actually make decisions about their lives and their families. And another thing is like it's very difficult for a pregnant woman to have a safe delivery during floods or a rainy season. So our project has been working with pregnant women. So I will share the story of Lisa. Lisa was pregnant during the monsoon, and she was an active member of our courtyard session. So she knew the risks. So she knew that she has to prepare a boat beforehand. She also have to plan her route, like how she will access the health facility and which health facility she will go. And also she has to arrange some blood donors who will be able to donate blood to her if emergency occurs. So she knew all this information, and this information made her prepared for a safe delivery. And when her labor began, she reached the hospital timely and safely, and gave birth to a healthy baby girl. And you can see the baby girl with her here. So this, like Lisa, there are so many pregnant women in our project were actually a bit confident and prepared, like even though like floods are being devastating and intensifying year after year. And but with this information, like how they are gonna they can make themselves more prepared, and how they are gonna face these challenges when they are pregnant, this kind of information actually helping them, and kind of making them prepared and less stress about this situation. And we are preparing young girls like Mosammat as well. Mosammat is telling she is prepared, and let me tell you how she is prepared. She's a college student from Nikli, and she has been working as a resilience volunteer with us. So what does a resilience volunteer does in their community? A resilience volunteer is someone who is awareing their community about the outcome of the climate-induced disasters, and if there are any early warnings, they are disseminates those information in their community so that they can get prepared beforehand. They are also work as the first time responder during a climate-induced disaster where they can. And we also provide them resources to make them capacitated to work as a resilience volunteer during climate-induced disaster. So Mosammat has been working besides her studies, and she also likes to play football. Apart from all this, she is an active resilience volunteer in her community. She whenever she collects information about a disaster that's going to be happen, she disseminates those information in her locality. She also encourages the young people, the children of that community, to be more climate aware, and also tell them about the danger that occur during climate induced disaster, mostly for the young children who has a risk to get drowned during the floods. So she has been a real climate agent in her locality, and she has been a role model for the young girls who are looking up to her, that they want to be like her. And she's also a role model of social justice. She raises her voice whenever something unfair is happening in her community. So there are so many girls like Mosammat. This was story of Mosammat, but there are so many stories of young girls like Mosammat who are actively working with us, who are making a great contribution to make their community resilient.
Let me stop you there, Jonaki Appa. Sorry to interrupt. Actually, could you please reshare the slides again? I think there is some spots when you're sharing the screen. So sorry for the interruption.
Can you see the screen now?
Yeah, we can see the screen, but there are some spots. So I think it's for the lagging. So could you, if it's better if you could share the slides again and then start over. Thank you so much.
Okay, can you see the resilience volunteer slide now?
Yeah, I can see the slides. We can see the slides actually, but there are some spots, I think, in your slides. Okay.
Okay, I will just
Will be
go
great.
on. Sorry for the technical problems.
Okay, thank you.
Now I will talk about the adolescents girls that we are being empowering. So I will be talking about the story of Jebin. Jebin is a school student. She's been studying in grade 7, and she has recently got her period. And as she lives in a flood-prone area, one of her concern is what will she do if she gets her period during flood? And if the flood is like intensified and devastating, she might have to take shelter in a safe house or a safe shelter. So how she's gonna control or like manage her period? And through our programs, she has joined some climate session. She has been aware that how climate change is having an effect in her areas, and she has also got information about like how she can make her self prepare for if she has a period for during a flood. So we have some IC materials which actually shows like how one can make a sanitary kit for herself and keep it with them when something like this, like flood happens, and so that they can use that sanitary kit and they can be safe. And there are some emergency numbers that we have been pasted on the walls of the schools, so that Jabin can ask for help if any kind of any concern related to GBB arises when she is in shelter. So now Jabin is a bit confident, and she is not afraid that things will get worse if she gets a period during flood, because she has a sanitary kit prepared for herself, and she keeps this ready. And whenever a flood occurs, she can take that to the shelter. I just told the Jabin story, but there are so many young girls like Jabin who are now a bit confident and prepared, and who knows how they can maintain their menstrual hygiene during flood, and how they can ask for help if there is a concern about GBB. And they are not only keeping this learning within themselves, they are also sharing this learning with their peers, their community, their parents. So they are kind of taking the lead, these young girls taking the lead to make their schools, their community, their family a bit more climate resilient. Now, last but not the least, the story that I will be talking about is Razia. She is a service provider. And as a service provider, her job is not easy because she has to work in a difficult situation, as you can already understand by the presentation that Arif Bhai gave, like the situation of the health facilities, and you have seen some photos. So the job is not easy for her, but we kind of tried to capacitate her so that she can provide better services to the people during a climate-induced disaster. Like we have trained her in MISP on snake bite management, because in some of the flood-prone areas, it's a real concern. Like when the flood water rises, there are so many snakes, and you can easily be bitten by a snake. So she has been trained on snake bite management, and she has also been trained on gender issues. So she is now a bit more confident in delivering her services during climate-induced disaster. And in addition to her primary role, which is providing services, she is also working as an climate agent of her community, because whenever she does this field visit, when she goes to visit the patients, she shares the preparedness information with pregnant women, new mothers, and adolescent girls, so that they can stay safe before floods, during floods, and after floods. So Razia, as I have said, Razia is not the only one. She's one of many. Like we have seen so many service providers during this project, like how they're even being in a really difficult ecosystem, they are actually providing very good services to the patients. They are doing field visits, they are having training, they are capacitated themselves. And it's also a call to action, like how we can make them more empowered so that they can have a bigger impact on the community. So these are the stories that I wanted to share with you. And now I will move on to a video that we have done previously, but it's not a human-centric story. It's about a health facility. And before showing this video, wanted to have this call in action, like how important it is for us and the government, on all the stakeholders, to invest in the health facility, because we want to have the impact of the on the human beings, but as well as we have to talk about the infrastructure as well, like how well is the infrastructure to be able to provide the services to the patients. And you have already seen the photos of health facilities, like there are not enough washrooms. 52% of the health facilities were closed during floods, and 93% of the health facilities are not prepared for any kind of disasters. And you have seen only 6% of the health facilities have a budget to actually invest to make their health facility a bit resilient. So in our project, we have tried to do some small mitigation activities in some of the health facilities. So, and the purpose of showing this video is to showing like how a small investment can actually give us a bigger impact in reality. So I will just show the video, and you can see like we have done minimal mitigation activities, but how it has impacted everyone in that locality.
ছিল না, রাস্তা খাদা ছিল, পিছলা ছিল। তখন কোনো মানে আমার আসতে অনেক সমস্যা হয়েছিল। এখন আলহামদুলিল্লাহ অনেক একটা ভালো একটা রাস্তা হয়েছে, এখন আসতে কোনো সমস্যা হয়নি। এখন যারা গর্ভবতী আছে তাদের সুযোগ সুবিধা হচ্ছে।
কথা ছিল আমাদের আসতে অনেক সুবিধা অসুবিধা হতো, এখন সুবিধা হয়েছে, রাস্তা পাকা হয়েছে, টয়লেটও আগে ছিল না, আমরা অনেক কষ্টে ছিলাম, এখন টয়লেটও হয়েছে।
আমি যখন ফার্স্ট এখানে আসলাম তখন এখানে বসতে পারতাম না, ছাদ দিয়ে পানি পড়তো, তো এখানে পুরো পানি জমে থাকতো। এখানে বসার জন্য অস্বস্তিকর লাগতো। আমি যখন সেবা দিব অস্বস্তিকর লাগতো, নিচে পানি থাকতো, উপরে যখন হালকা বৃষ্টি এলে পুরা শরীর ভিজে যেত। এমনকি গর্ভবতী মা যখন আসতো তারাও অনেক কষ্ট পেত।
আগে আমাদের বর্ষাকালে এদিক দিয়ে হাসপাতালে আসতে অনেক সমস্যা হতো, বৃষ্টি পানি খাতা এসব। এখন রাস্তা পাকা হয়েছে, আমাদের কোনো সমস্যা হয় না। গরমের দিনে গরম লাগতো, বাচ্চা কাচ্চা নিয়ে আসলে অনেক কষ্ট হতো, এখন ফের আসতে।
Sorry. So this is my presentation. Thank you so much for listening to me. And please feel free to share if you have any questions or suggestions, anything in the chat box, and feel free to contact us if you want to know more about these stories, and if you want to access more knowledge products or communications products. Thank you. Over to Azwad Bhai.
Oh, thank you so much, Jonaki Appa. Those were some wonderful impact stories. So actually, we all are adapting in some ways. So we are observing that in the grassroots levels, the adaptation are actually quite different. So that is what makes us unique in every way. So thank you once again. So like I said before, participants can share similar stories and participate in the discussion. The floor is now open. And since it's a learning session, we can share and transmit knowledges. So I would like all the participants, those who are interested, they can raise their hands and ask questions, or they can type in the chat box so we can respond accordingly. So the floor is now open. If anyone have any pertinent questions, you can raise your hand and one of us will respond. And thank you again, all the presenters. And I think there is a question in the chat box. So regarding livelihood, how the livelihood process could be sustainable after the project period. So I think Manbirapa, if you can take that question. So you can unmute yourself.
Thank you, Ajay Bhai. So yeah, um, uh, what we think is that, we didn't actually intervene anything in the livelihood. We linked those women with the existing government systems, like the government Department of Agricultural Extension and their training program, Department of Youth Development, their training program. And also we linked them with the available services which they were available before, but the community didn't have knowledge about that, how they can access it. Now, even women said that they didn't have knowledge about the community clinics and all that. So now we've seen that women group members are applying to Department of Agriculture Extension for training of new candidates or new participants from the community. And there people who are not part of the group, they also sought seeds and other things for their own cultivation, for getting them for free from the agricultural extension. So these are also, they now know that these are the things that needs to be there for their cultivation, and so they gain access from the market. to buy this. Because these are localized and we have linked them with the local services, this will be sustainable. And also we have our partners are localized and they will be there even if after the project ends. So they will always have access to our partners and their activities, so they can also gain support from the partners. And there, what we say that there is a peer level effect from the wider community is one women, the wider community is getting impacted. And so also we have climate volunteers who are trained on disasters and how they can prepare the community. They will also be a support to the groups. So all these processes and all these trainings and the capacities and the linking and the mobility that they have gained will be sustainable. That's what we feel, even if the project is not there. Thank you.
Thank you so much for your response, Manvirabba. So I'm requesting the participants, if you can ask questions or write in the chat box, the floor is open. So we encourage you to share similar experiences that you have encountered. And thank you for your generous comment, Mr. John Alabidin. We really appreciate it. Anyone who wants to ask questions can raise their hand and we will pick that question and let you in. And also use the chat box. I think participants can actually share which stories they have liked the most. I think all of the stories that have been shared are great. So at least do response. Which stories have you liked the most that has been shared, and the video as well. So we are eagerly waiting for your responses. Thank you so much again for joining. So if the participants don't have any pertinent questions, so I would like to thank everyone again to join this session with us in this session. So please reach out to us if you want to know more about our projects and works. So we would be grateful to share our resources with you and learnings as well. So let's call it a day. And I think we can again, thank you again for joining the session. So since there's no questions, I'm closing the session. Thank you and goodbye.
Hello, Azwad Baribhai. I'm
Yes.
requesting you to ask the attendees to open their cameras and take a screenshot as record. Can you do that?
Okay, okay. So I would like to request all the panelists to open the cameras. So yes, Tasin bhai, you can take the screenshot.
I'll do that.
Oh, and one more thing. I think one of our speaker is missing here, Arif Azad Khan. I'd like to request Arif bhai to please raise your hand so that you may add into the list. Arif bhai, are you there?
No, he's not. I think we can just take the picture. Yeah.
Okay.
Is it Arif Azad Khan?
Yes, yes. Please make him
Yeah.
co-host, and I would request Arif bhai, please turn on your camera.
Yeah, he'll be joining as a panelist soon.
Okay, Arif bhai, please turn on your camera so that. Okay, thank you, Tasin bhai. Please.
Thank you. I'll now take the picture. Smile, everyone. Thank you so much.
Thank you so much, and do share the pictures and the recording as well. Oh, thank you everyone again.
Thank you.
Have a nice day.
And thank you, Gobeshona, for inviting us and giving us this opportunity. It was really nice. Thank you.
Thank you.
Pleasure to have you all. Thank you. Bye-bye.
Bye-bye.